All right, future clinicians, let's get right into it. Today, we're tackling a classic infectious disease, but we're looking at it from your unique perspective, the oral cavity. We're talking about measles, or rubeola. Now, you probably think of measles as a kid's disease, a body rash that's a pediatrician's problem. But what if I told you that the earliest, most telltale signs show up right in the one place you're an expert, right in the mouth? So, that leads us to the big question for today, really the whole point of this explainer. How can a dentist, how can you, spot measles a full day or two before a doctor even has a clue? Well, the answer is all about your unique viewpoint and knowing your oral pathology. Honestly, it puts you in an incredibly important spot when it comes to public health. And hey, just a quick aside, if this kind of stuff gets you excited, seeing how the mouth is a window to the rest of the body, you should totally check out the Master Oral Path channel on YouTube. We do a ton of deep dives like this. It's a great resource, for real. Okay, so to break this all down, we're going to follow a really simple but super effective framework. It's something you should use with every single patient. Listen, look, and plan. 3 easy steps. This approach is going to help us piece together the clues for measles, right from the second a patient sits down in your chair. So let's start with phase 1. Listen. This is all about the patient's story. Seriously, before you even think about picking up an instrument, the patient's history is where you'll find your first clues. You're basically listening for those early, body-wide signs of an infection that are going to pave the way for what comes next. Okay, so what's actually happening in the body? Well, it all starts when someone gets exposed to the Paramyxovirus, usually through respiratory droplets. After a week or 3, that's the incubation period, the virus sets up shop in the respiratory tract, spreads to the lymph nodes, and then, boom, it hits the bloodstream. That's called viremia, and it's when the patient starts feeling, well, just awful. This is what we call the prodromal phase. So they'll tell you they've got a fever, they feel run down, they've got a running nose, that's coryza, and maybe even conjunctivitis, those classic red watery eyes. They might also complain that light hurts their eyes, photophobia, and that they have this nagging cough. Now, any one of these just sounds like a regular old virus, right? But for you, this whole collection of symptoms should be the first big red flag. All right, so we've listened. Now it's time for phase 2. Look. This is the clinical exam, and this, my friends, is where you shine. It's where your specific skills come into play, and where you can literally make a diagnosis before anyone else. You know how to look in all the nooks and crannies of the mouth, and that's exactly where we're going to find our smoking gun. And what are you looking for exactly? You're looking for these things, Koplik spots. This is a huge deal. They're what we call pathognomonic for measles. That's a fancy word that just means if you see these spots, it is measles. End of story. So what do they look like? They're these tiny red spots. We'd call them erythematous macules. And right in the center, there's a little white or bluish-white dot. The classic description, and it's a great one, is that they look like little grains of salt sprinkled on a red background. And where do you find them? The location is crucial, right on the buccal mucosa, usually across from the molars. And this is exactly why you're in such a unique position. First off, their location, the buccal mucosa, that's your turf. But even more important is the timing. These little spots show up 1 to 2 days before that famous skin rash ever appears. That's your golden window for an early diagnosis. Now, of course, you've got to think about what else it could be, right? Your differential diagnosis. You might think, hey, maybe they're 40 granules, but nope, those are more yellowish and they're not inflamed. Or you might think of canker sores, aphthous ulcers, but those are way bigger, they're painful, and they have that classic yellow center with a red ring around them. Koplik spots are totally unique with that salt on a red base look and their specific timing. That's why they're pathognomonic. And fun fact, they're named after Henry Koplik, the pediatrician who first put it all together. So let's put this all on a timeline to see how it plays out. The patient gets exposed to the virus. Then, for a week or 2, you've got the incubation and those early flu-like symptoms. But right here, look at this. This is the sweet spot. This is when the Koplik spots pop up in the mouth. And it's only after that happens that the skin rash finally starts. This order of events is super, super reliable. If you can spot those spots, you can give the patient and their doctor a heads up before the most famous sign of measles even shows its face. And when that skin rash does finally show up, it follows a very predictable pattern. It's what we call a maculopapular rash, which just means it has both flat red spots and some raised bumps that can kind of blend together. It almost always starts on the head and neck, think behind the ears and along the hairline, and then it just travels downwards, covering the torso and then the arms and legs. And here's the kicker. By the time you can even see this rash, the person has already been contagious for several days. Okay. So this brings us to the last piece of our puzzle, phase 3, the plan.
You've listened, you've looked, and you've found these incredibly specific signs. So, now what? What's the next move? This is all about putting the pieces together and figuring out the best course of action for your patient.
Most of the time, the diagnosis is going to be purely clinical, especially if you have a patient who isn't vaccinated and they've got that classic trifecta: the flu-like symptoms, the Koplik spots, and then the skin rash. That combo is usually all you need. But sometimes, maybe for public health reasons or if the case isn't super clear, you can get it confirmed with lab tests. They can do blood work to look for specific antibodies, the IgM ones, that signal a recent infection, or they can even do a PCR test on a throat swab to find the virus's RNA directly.
Now, this is pretty cool. Beyond what you see in the clinic or find in the lab, measles leaves behind a very specific fingerprint under the microscope. If for some reason a biopsy was taken from lymphoid tissue, like the tonsils, you'd find these things called Warthin-Finkeldy giant cells. They're these huge multinucleated cells that are a direct result of the virus messing with the immune system. They are the microscopic signature of measles. You're probably not going to be diagnosing it this way, but it's really cool to know, and it kind of completes the whole picture of the disease.
So you've pretty much nailed down a diagnosis. Now for the last and maybe most important part of your plan: management and prevention. And this is where you switch hats from being a detective to being an educator. You have to be ready to explain to the patient or their parents what's going on and what they need to do next.
Here's the key thing to communicate. There's no magic pill or antiviral for measles. The treatment is all about supportive care. That's it. The goal is just to keep the patient comfortable while their own immune system does the heavy lifting. So you're going to recommend the basics: lots of rest, tons of fluids so they don't get dehydrated, eating what they can, and using things like acetaminophen or ibuprofen to help with the fever and aches. The good news is the disease just has to run its course. In a normal case, it's over in about 2 weeks.
And this all leads to the single most important message we have about measles. The whole thing is preventable. We have the MMR vaccine for measles, mumps, and rubella, and it is incredibly safe and effective. It gives you long-lasting protection. The only reason this disease isn't a common and frankly dangerous part of childhood anymore is because of widespread vaccination.
So let's wrap up with this final thought. Measles is just such a perfect example of how the mouth is not its own little island, right? It's a window into what's happening in the entire body. By just using that simple listen, look, plan framework, you're doing so much more than just fixing teeth. You're on the front lines, able to spot major systemic diseases. So the question I want you to take with you through school and into your career is this: how else are you going to use your unique skills to make a difference in a patient's total health?